Yeah, no problem. Yeah, no problem.
Everyone, this is Dr. Kozman.
Hi. We opened an office on Genesee Street near Budweiser back in 2017. We're in the same building as Dr. Triana, Compassionate Family Medicine. So if you need a cardiologist, we're nearby. So I'm just going to talk briefly. I know you probably all have a lot of questions. I'm not sure, how many of you have heart problems, but I'll be sure to save a lot of time for questions later. So this is the heart. Okay. So one of the more common reasons that you might end up going to a heart doctor is if you got chest pain, okay? So there's a lot of reasons for chest pain, and believe it or not, most of the chest pain that people get aren't related to the heart. It's usually related to the muscles and bones in the chest. So what causes the chest pain is blockages in these arteries that we call the coronary arteries. There are these teeny tiny things sit on top of the heart. There's three big ones. So coronary, corona means crown in Latin, I guess, so because they sit on top of the heart like a crown. So you start getting cholesterol buildup when you're like about 20 years old. And then over a long time, the cholesterol plaque can get so big that it can break open and a blood clot forms, which can diminish the blood flow down the artery. If it blocks the artery completely, then you get damage to the heart muscle that we call a heart attack. All right. If it doesn't block the artery completely, then you can start getting chest pain. Usually it's exertional that we call angina. So heart pain that's kind of been going on for a while usually is pretty predictable with any kind of like exertion that you do, that it'll come on. If you have chest pain when you're just sitting there watching TV or, it wakes you up from sleep or something, that's probably not angina pain. It's probably something else, all right? So it could be 80% of heart attacks present with some kind of pain from your jaw down to your belt. All right. It's usually a tightness. It could be in your back, your arms, your neck. If it lasts more than 30 minutes, then we're getting in the heart attack range when you could be damaging your heart muscle. So it's not something you'd want to play around with. If you suspect you're having a heart attack, don't drive yourself to the hospital. All right. Just call an ambulance because, it can be associated with heart rhythm problems, and you don't want to be passing out at the wheel, okay, when you're on the way to the hospital, okay? So if somebody comes to my office with chest pain, I usually ask them a bunch of questions. So the most important thing is what we call risk factors, all right? So those are things that would lead to blockages in the arteries. So the most common one is high blood pressure, all right? So very, very common problem. It can lead to it increases kind of the shear stress on the inside of the artery, so it can make these cholesterol plaques rupture. It kind of thickens the wall of the artery. It does a whole bunch of other stuff. Thickens the wall of the heart itself. Can make the top part of the heart dilate, what we call the atria, all right, and that can lead to irregular heartbeats, so we call atrial fibrillation. But so high blood pressure is a big issue. The next one is the cholesterol levels. So you want to make sure your cholesterol is in the normal range. That would be, we look at what we call the LDL, or the low density lipoprotein is the most important one. That's the bad cholesterol. And that needs to be below 130 for most people. If you already have heart disease, you need to be below 100, and some people recommend you should be below 70, okay, for that LDL. The other thing is diabetes. A lot of people have diabetes. Half of people over the age of 80 have diabetes, and that can lead to coronary disease also. Family history. So what's a family history? Would be somebody who, so it would be either a parent or a sibling that has coronary disease early in life. So that would be a man under the age of 55 or a premenopausal woman that has heart disease, generally under the age of 65. The other risk factor is smoking. Even if you stop smoking, you still have kind of like set a process in motion that could lead to coronary artery disease. All right. So those are the things I ask when you come in. So, you know, if you see, you know, what I found is patients don't like harping on blood pressure all the time, but it's like extremely important, and that's, you know, what I end up treating a lot. And the cholesterol also. You need to be very aggressive, particularly if you already have coronary artery disease. So what kind of tests could I ask for if you come into the office with chest pain? Because angina is exertional, you need a test where you exert yourself. So it would be like walking on a treadmill. A lot of people can't walk on treadmills, so we kind of invented this alternate way of doing it by giving a chemical that kind of stresses the heart. So there's two types of chemical stress tests. One's nuclear and the other one's using echocardiography or ultrasonography. So with the walking treadmill, we always use ultrasonography. With the chemical one, if we use ultrasonography, we got to give a chemical to speed up your heart rate called dobutamine, all right? And we watch your heart kind of beating on a TV screen. We do that in the hospital. It's kind of a little more risky than a regular stress test, even though they are all very safe. And just the setup is better at the hospital. So we watch your heart beating on a TV screen and see if there's a blockage in one of the arteries. So what will happen is one part of your heart, when your heart rate speeds up, won't be beating normally. It'll stop moving. All right, and we can see that on the echocardiogram, and you might get chest pain, you might get changes to your EKG. The other test that we have is in nuclear medicine. The generic name for it is called a Lexy Scan. All right, that's the name of the chemical that we give that stresses your heart. So what that does is it opens up the arteries. And if there's already a blockage in one of the arteries, the blood flow can't improve. So what will happen is we give another chemical, which is a small amount of nuclear material. The name for it is sestamib, and that gets picked up by the heart muscle. And if there's a lack of blood flow to the heart muscle, when they measure the radioactive counts, there'll be like a cold spot, all right? And that'll indicate that there's like a lack of blood flow to the heart muscle. The thing with that is it's much more involved. You got to go through nuclear medicine. It usually takes 2 days. The good part about it is it basically picks up everything. You know, if there's any kind of small artery or any kind of minor problem, it'll pick it up as well, whereas the echo might miss a few, maybe like 1 in 10, especially for the smaller arteries, all right? So I don't know if any of you have had that test. They tell you like not to drink coffee before because that can interfere with the test, not to smoke before because that can interfere with the test. So that's the testing that we do. So what if we find a problem on the test? Generally, you could do one of two things. Either take medication to kind of relieve the angina. So that would be, there's nitroglycerin, there's beta blockers, which anything that ends in the last 4 letters, OLOL, all right, that would be a beta blocker. Hey, Jackie. Jackie used to work with me a long time ago. Or calcium channel blockers, that would be like diltiazem or something like that, to relieve the chest pain. Most cardiologists want to know what's going on, particularly if you don't have a history of coronary disease. You know, picture's worth 1,000 words. So what they'll do is do what they call a heart catheterization, all right? So What we do with that is we pass a thin tube. Now most of the procedures are done through the arm, okay, the radial artery. And we pass a thin tube. Tube's about this wide, okay, from the wrist up to the heart or from the leg up to the heart, and we take x-ray pictures directly of these coronary arteries. The tube goes right into where the arteries start, and we inject dye and take x-ray pictures, all right? So we can see the outline of the artery. So the good thing about it is there's no nerves in your blood vessels, so you don't feel a tube going out, which is great. You know, all you got to do is just lay there and you have no idea what the physician's doing for the most part, right? You might feel a little discomfort in the wrist when they numb the skin, but once they're in the artery, you don't feel anything generally. So the other good part about it is if you do have a blockage, sometimes they can fix it at the same time with a tiny balloon, okay? It's like really teeny tiny. They pass a wire down the artery, pass a balloon over the wire, inflate the balloon, and that opens up the artery, kind of pushes the cholesterol to the side, and then they put this metal coil that acts like a scaffold and holds the artery open, okay? And that's called a stent, all right? The stent becomes part of your circulation. The cells kind of grow over top of it, and you can forget you have it. They're teeny tiny. So it's even smaller than kind of like spring on the inside of a ballpoint pen. Okay, they're minuscule. All right, but it looks big on the screen because it's all magnified, so we can see it clearly. But so some people have a lot of blockages, all right? So what they might need to do very rarely is what they call coronary artery bypass surgery, all right? So what they do for that is they kind of like create a detour around the whole artery, all right? So they take veins from the legs, or there's these arteries on the inside of the chest that we call mammary arteries, which women use during breastfeeding. But why everybody's got them, I don't know. But they're very convenient for bypass surgery. And what we do is implant them during open heart surgery into these arteries here, kind of sew them in, and they just stay there permanently, all right? And they kind of redirect the blood around where the blockages are. You can use veins from the legs also, and kind of put them in the chest and kind of redirect the blood flow. So bypass surgery would sort of be like repaving the road completely, okay? Whereas stenting would be more like fixing a pothole, all right? So the problem with stents is you don't fix the whole artery, you just fix a short part of it. So you could develop another blockage, like not too far upstream or downstream, where you need another stent, all right? Whereas with bypass surgery, they bypass the whole artery. So it's kind of like putting money in the bank. It's kind of like you can prevent problems down the road. The only problem is it is open heart surgery. They do cut your chest open to do that, and it's a big deal for most people to go, or basically for everybody to go through that. The only good part about it is you don't have to worry about it for another 15 or 20 years because the grafts last a long time with all the medications that we have, the cholesterol medicine and all that. So. All right, so that's coronary disease. That's what I treat the most. Like I said, most people come in with high blood pressure issues, so the blood pressure pills are really important to know, okay, when you're coming in. An awful lot of people take blood pressure medication, okay? It's the most common thing I treat, so it's real important you know your medications when you're coming in. So there's several classes. The most common is what we call ACE inhibitors or angiotensin converting enzyme inhibitors. So they're good because, particularly if you're diabetic, they protect the kidneys, all right, from damage and can prevent you from going on dialysis. So they're drugs that end in the last four letters PRIL, P-R-I-L, okay? Anything that ends in those is an angiotensin converting enzyme inhibitor, and they're often first-class drugs, and they prevent kidney damage in diabetics, and they're actually very good for preventing progression of coronary artery disease, all right? Next class, which I've already mentioned, are what they call the beta blockers. So that's anything that ends in OLOL, O-L-O-L, like metoprolol, bisoprolol, atenolol. So that lowers your blood pressure. It also slows your heart rate. that could be an issue for some people. It can make them fatigued, tired. I know a lot of younger men don't really like it. It also causes like erectile dysfunction, so they really hate that one. So the other classes are calcium channel blockers. So that would be anything that ends in INE, like amlodipine, felodipine. They're very good for blood pressure. They also help relieve chest pain related to angina. Diuretics, so those are water pills that we call them. Most common ones called hydrochlorothiazide or HCTZ. It's a very mild diuretic, lowers your blood pressure a little bit, usually used in combination with other pills. There's another one called furosemide or Lasix, which we give a lot if there's any kind of like symptoms of congestive heart failure. So that would be like leg swelling, trouble breathing, fluid on the lungs. So a lot of times the coronary disease or the high blood pressure can weaken the heart muscle, okay? So when that happens, the blood kind of backs up in the lungs and the water filters out of the blood. Then you get trouble breathing, all right? And that's called congestive heart failure, all right? Sometimes you can get congestive heart failure even if your heart's pumping normally. It could be due to a lack of blood flow from the coronary disease, or it could be due to a thick heart muscle from high blood pressure, all right? So the treatment basically is very similar. It's all those same drugs that I just mentioned. The angiotensin converting enzyme inhibitors, the beta blockers, blood pressure control, treating coronary disease, diuretics, that'll help clear up the breathing problem. Sometimes if you fix the arteries with bypass surgery, the heart function can get better too, or with stents, so the congestive heart failure can clear up. There's another issue with people that have chronic heart problems, particularly chronic high blood pressure, is this abnormal heart rhythm called atrial fibrillation. Okay, well, there's an epidemic of atrial fibrillation now. So what happens is because the heart muscle is stressed, you know, either by coronary disease, high blood pressure, whatever, it puts more stress on the top part of the heart that we call the atria. All right, and they dilate and then they start acting funny, all right? They start contracting a lot, like even up to 500 times a minute, all right? The only good part about it is the bottom part can't keep up at 500 times a minute, so it usually goes around 110 to like 140 a minute. Problem is, for most people, that's like awful, okay? They don't like that feeling, you know, the heart racing. You could develop congestive heart failure. If you don't feel the heart racing, you could get chest pain. You could feel like your heart's gonna pop out of your chest. So we try to slow it down with medications like beta blockers. And digoxin is another one that we use. It's kind of an older drug. So the only problem when the top part's beating at 500 times per minute, the blood stagnates, okay? And a blood clot can form in the atria, which can travel, all right? And what we're worried about is it can go to your brain and cause a stroke, you know, and a stroke is a really, really big deal, okay? And we want to avoid that at all costs. So what we do is if you do develop atrial fibrillation, we put you on a blood thinner, all right? We're kind of fortunate now because over the past 5 years, we've got some really good blood thinners. We used to use this drug called Coumadin, which was kind of very unpredictable depending on what you ate, but now there's new ones out that can that have a more steady state level to help prevent blood clots in the heart. There's no monitoring needed. They go by the name, they usually end in the three letters BAN. So you have apixaban or Eliquis, you have rivaroxaban, which is Xarelto, and then the last one's Pradaxa, okay? So they're more predictable and they can help prevent the strokes. If you don't take any blood thinner, the stroke risk for the average, I would say 70-year-old with normal heart function would be in the range of 2 to 3% per year. All right, if your heart function is decreased, the risk goes up astronomically, all right, if it's not pumping very well because there's more blood stagnating, all right? So it'd be real important if you do have a weak heart muscle and atrial fibrillation that you definitely need to be on a blood thinner, all right? So the other thing is, yeah, we're very aggressive about cholesterol treatment also. That has kind of like made people live longer, even though people don't like to hear about it for some reason. But those drugs are extremely important. So that would be what we call the statins, or S-T-A-T-I-N. So atorvastatin is a very common one, lovastatin, rosuvastatin, simvastatin. They're all real important to help lower cholesterol. It helps prevent coronary disease, makes you live longer, and I'm fairly certain a lot of the longevity we're seeing now is because of those drugs. So they're important to take if you do have coronary disease or high cholesterol levels. So there's some procedures that can be done. I'll kind of go over them kind of briefly. So for atrial fibrillation, there is a similar, the atrial fibrillation can coexist with this other heart rhythm called atrial flutter, where flutter is more organized and there could be like an abnormal circuit around the tricuspid valve, which is over on this side of the heart, the right side. It's right in there. All right, there's the tricuspid valve. So they can do what they call an ablation to kind of get rid of it. So what they do is pass a plastic-coated wire up from the leg to the heart, and they can find that abnormal circuit, believe it or not, and do a low-energy burn about the size of a pinhead to kind of get rid of that. The ablation procedure with atrial fibrillation is much more complex, doesn't have as good results, and is more involved. Some people, on the other hand, instead of having a fast heart rate, they have a slow heart rate. Most common reason why is what we call sick sinus syndrome, which the coronary, the heart's natural pacemaker is in the right atrium over here, and sometimes when you get older, it can get scarred up. Then it starts acting funny, and it can slow down suddenly and stop. And most common symptom of that is passing out. All right, it could just be fatigue if your heart rate's really slow, or trouble breathing due to congestive heart failure because the heart's not pumping as much. But if your heart does get really slow with any of those kind of symptoms, then you might need a pacemaker. So what that is a mechanical device that kind of like makes sure your heart keeps beating. All right, so you don't get symptoms like shortness of breath, passing out, dizziness, extreme fatigue, all that. In people that have weak heart muscles, they're more at risk for this extremely dangerous heart rhythm that we call ventricular fibrillation, all right, which is basically your heart stops. So people with weak heart muscles, congestive heart failure, might need what they call a defibrillator. Okay, so a defibrillator is kind of like a special pacemaker that continuously monitors your heart. If your heart does slow down, it'll speed it up. It acts like a pacemaker, but if you do develop ventricular fibrillation or your heart stops, it'll give your heart a shock from the inside to bring you back, all right? Save your life. So basically everybody with really weak heart function now would be a candidate for a defibrillator. We don't usually wait for the first episode of ventricular fibrillation because it could be your last episode of ventricular fibrillation, so we kind of preempt that and put that in most people with weak heart muscles. So basically, when you go to the doctors, you should kind of like be familiar with your past medical history. I mean, have you had a heart attack? Do you have stents, bypass surgery? Where was it done would be important, because we can ask for the information. A lot of the computers are linked now with electronic medical records. So I'd say half the hospitals in the country are all linked together. So it's really easy to access information. You just need to tell me, where it was done, kind of thing. And if it's not linked, we can ask for it. The medications are real important. You got to know what you're taking, how much you're taking. You might want to write it down. Your hospitalizations, particularly recent ones within like a year or two, would be important to know. And also, you know, like you should know what you want done. A lot of these procedures are invasive and kind of painful, and you should be discussing it with your physician, you know, as to like whether how much of a benefit is it going to give you before you go into it. What could you expect from the procedure? Will it prolong your life? Or will it just treat symptoms? Those would be important things to ask. Ann, did you have anything you want to add?
No, I really everything in terms of that, going to the doctors, and what the doctor can do, and what kind of problems you have. But I did want to tell them about the information that the ambulance people and the emergency people that take you to the hospital need. So could I?
Yeah, go ahead.
I belong to the Camillus Fire Department. I'm part of the EMT service that they provide. And several years ago, they had this big push on a vial of life, where you put down all your information, especially your allergies and your current medications and past surgeries. And like you said, really the ones that were recent, the past 2 years are so important. And we would encourage the people to write them down and then put them in a bottle, like an extra large pill bottle, in their refrigerator. Well, that works if you don't have many other things in your refrigerator. But if your refrigerator is like most people, the ambulance people just didn't have time to clean it out and find your vial of life. So now, especially since there are so few ambulances and fire departments that can respond quickly, because we've been very busy with a lot of drug abuse problems and just less volunteers. Out in the suburbs, a lot of everything is run by volunteers, not paid people. And so it takes us a while to get to you if we're busy on other calls. And also, if we get there and you've got 10 medicines that you take, and 4 doctors that you've seen, and 2 surgical procedures, we're supposed to write it all down before we take you to the hospital. And if you're having chest pain, minutes count, okay? So we're now pushing a new thing. We call it the vial of life, but really what we need is a plastic bag attached to the front of your refrigerator. And you're supposed to complete this, and you probably should fill out a new one every year, or after every big procedure where your medicines have changed. And you put down the date completed and your information, especially allergies, okay? Because I have been there when people have been given a medicine and have died because they were allergic to it. Most of the ones I saw, we couldn't even ask them. They weren't conscious or they were confused. It's a senseless death if we have one of these papers, okay? So we need this filled out and then placed with a picture of yourself. It's the lawyers of the land, because we want to make sure we've got the right patient that goes with the paperwork. And put that in a plastic bag and put it on the front of the refrigerator. And I brought some with me. I have enough to give each one of you. There's 2 papers. One's the instruction, one's the information sheet. And then you have to add to it your picture. Some old photograph that looks something like yourself would be good. Because sometimes when you call us, we're alone. And there's maybe 4 other people in your household and they're out of the house. And if they grab the wrong person's plastic bag, then we're really in trouble. So we need a picture too. And you fill it out, and then every year, Valentine's Day, go back and fill out a new one. For some of you, absolutely nothing will have changed, but most of us at our age, things change. And we even need to know the medicines that you take that the doctor didn't prescribe. Like
if you're taking some vitamins, or if you're taking quite a bit of ibuprofen, you know, the Advil or whatever, over-the-counter things. We need to know those too. And that way, there'll be no delay. They'll come to pick you up, they'll get your thing from the refrigerator, and they will pack and you into the ambulance and take you to the hospital. And we'll have current information, and we'll know your allergies, okay? Any questions about that? You'll be hearing more about this, I think, because they're going to do, Dr. Khan's going to do some publicity on this.
Shouldn't the family doctor have most of the information?
Shouldn't who?
The family doctor. Should
Right.
have most of it.
Right, but what if it's 2 o'clock in the morning? How are we going to reach you? You know, that's the problem. And sometimes even 2 o'clock in the afternoon, he may be on vacation, or he may be operating.
But the computers are connected still.
Right, that means somebody has to be in the office to release the computer information to you. It is true, it helps, but we know from dealing with thousands of people being picked up, this is much safer, much quicker. And a lot of times you have like 5 doctors. Well, which one do we call? You know, and it's just a matter of time. And time is life sometimes, especially when it's the heart. If you had a problem with your big toe, yeah, we probably would have 12 hours. But if it's a problem with your heart, you might only have 2 hours. I'm just going to pass these around.
Anybody have a question? Okay. All right.
Yeah, there seems to be a lot of different medications for each symptom that you mentioned. How does a doctor pick one? I mean, I don't question, what my physician take. I take whatever he recommends.
Right, yeah.
But there seems to be so many, and if
Yeah.
you're watching TV, it seems like every other commercial on TV is for another different medication.
Yeah, I mean, for me, it's just basically my experience with the medication, you know, like who's done well, who hasn't, you know. Cost is another thing I worry about. You know, I try not to go for the more expensive version if there's a cheaper version. Once a day versus twice a day, so people tend to be more compliant with the once a day, you know, medications. Side effects, so there's a big class of drugs out now called the ARBs, or angiotensin receptor blockers. So that's everything that ends in SARTAN, sartan. So they basically have almost no side effects. So they're getting prescribed left and right, but they might not have as much benefit as some of the other ones. So I mean, everybody's got their own preferences. So when it comes to medications, I wouldn't worry about it. I mean, procedures are kind of different, like because they're involved with much more risk, kind of thing. So, but you should probably just make sure you understand what the procedure is, why you're going through it, and all that. So, yep.
I'm scheduled Dr. Jamal Ahmed because I put a new battery in the Tuesday.
Okay.
I thought maybe you could do it today, so I wouldn't have no chance of that.
Yeah, so,
Do I need someone to
I would ask them, they usually give you a sedation, so you probably should get a drive home, because, the sedation hangs around for a few hours, so it's like that with any procedure. They give you sedation, so you really can't drive home after.
I had open heart surgery 4 years ago.
Wow, that was a long time. Yeah.
The battery is 9 years old.
Yeah, usually they last about 10 years. Yeah, so.
I had the defibrillator go off 8 times.
Oh wow. Okay.
Boston Scientific.
Yeah. Okay.
Off twice. 2
Yeah.
days later, it went off.
Yeah. Yeah, it went off for the right reason, right? Or it wasn't? Yeah.
When it first went off, I went in the hospital, and the guy from Boston Scientific was in a hurry for the technician, so he didn't hang around. So Jamal Ahmed could see me, gave the information. Head nurse.
Okay.
Head nurse don't know anything about heart. Boston Scientific fired him, to make long story short.
Oh God. Okay.
Yeah.
Okay. But did it save your life? Yeah, it did. Oh, okay. So you had other questions? Yeah. Yeah, so the nuclear ones, it'll pick up basically everybody, but they have a lot of what they call false positives. So in men, kind of the diaphragm can get in the way. In women, it's the breast tissue. Depends on a number of things. My personal, really heavy people, I tend not to order the nuclears because they almost always come back positive. The echo is the trade-off. So the dobutamine. So we miss maybe about 1 in 10, with the dobutamine. But the nuclear basically picks up everybody, but has some false positives. The echo we do miss like a small number. Yeah. So nothing's 100%. Yeah. So yeah. Yep.
Just out of curiosity, in today's technology,
Yeah.
pacemaker defibrillators,
Yeah.
how come they haven't been able to get a rechargeable battery?
Yeah, it's a good question. They're working on it. Yeah, batteries always seem to be the problem, huh? It's like even with like the electric cars, and all that. So yeah, but they're working on it. Yeah. So yeah.
Defibrillator goes what, you say 7 years?
It depends on how often you use it. So if the pacemaker is just sitting there and it's not pacing at all, you might be able to make it 15 years. If you are pacing a lot, then probably 10 years would be the maximum. Yeah. So yeah. Yeah, you have no idea. It's only when they check it that they'll know whether it's pacing all the time or not. So yeah. Yep.
I would like to thank you personally for the services that you've done for me. I had you for our second opinion,
Okay.
and
Yeah.
down the bottom.
Okay. Great. Okay. Glad I could be of help. So,
Highly recommend you.
okay. Thanks. Thank you. Thanks. All right. Okay. Any other questions? Yeah.
Stress will cause heart problems too.
Yeah.
Stressed out,
Yeah.
chest pain. Easy example right now.
Okay. Yeah. Yeah. I mean, everybody's got stress, so it's kind of like people who have like chronic pain problems tend to have more coronary disease. Like what I've known is people with like back problems and all that. So. Yeah. All right. Yeah, no problem. It's my pleasure. Thank you.
Him and David are having a discussion. They want to put new valve in.
Okay.
Green says